Hi, my name is Haley and I am a nursing student at the University of Michigan. Today I will be presenting a patient to you from the Ann Arbor VA. Patient is an 88-year-old Caucasian married male. Although retired now, he previously served as a member of the United States Air Force and after was a General Motors employee in both America and China. Patient was admitted to the Ann Arbor VA on February 1st, 2013 for treatment of an infection that presented in the toes and then spread through the body. Although evaluation and treatment of the infection has only been for a few months at this facility, the patient recalls that the pain in his feet due to the infection began sometime in March 2012. At this time, there is no pain at the infection site, but mild pain occurs in later hours of the night. The infection has taken a toll on the patient's ability to complete daily activities. He is currently unable to walk and uses a wheelchair. Patient has previously been admitted to the hospital for wisdom teeth removal when he was in the Air Force and had surgery on his gallbladder 5 years ago. Other than that, there is no history of medical illness. Currently, patient lives with his wife and has a supportive family. His wife is frequently at the bedside, and both children and grandchildren visit every so often. To his knowledge, he is up to date on all immunizations, has no pharmacological or non-pharmacological allergies, and has no family history of illness or disease. Patient is considered a poor historian, and after further discussion with his healthcare team and family, a few more medical concerns came to light. Patient suffers from myasthenia gravis and has esophageal and thyroid issues related to this disease. He is also diagnosed with pernicious anemia and suffers from atrial fibrillation, for which he has a pacemaker. It was noted that the patient has an enlarged liver, but at this time the cause was not mentioned. When reviewing patient health history, patient stated he was on the verge of being diabetic, but was not yet at that point. But after further consultation, it is established that he is currently a diabetic. At this point in time, patient is being treated with several pharmacological interventions. He is on numerous vitamin supplement medications related to his pernicious anemia. Patient receives 325 milligrams of aspirin for his atrial fibrillation. He is also on 40 milligrams a day of lisinopril for his hypertension related to AFib. Patient takes 200 milligrams per day of gabapentin for nerve pain. Patient is on 20 milligrams of prednisone tablets each day and 150 milligrams of ranitidine. He's on several medications for his infection as well. Patient takes insulin for his diabetes and is prescribed moisturizing cream for his skin. The first examination performed on the patient was an integument exam to determine any changes related to his infection. Patient appeared to be alert and in a sitting position. He had a respiratory rate of 12 and a pulse of 68. Patient was not sitting erect and appeared relatively hunched over. Patient appeared to be well-groomed and well-nourished. Upon inspection, it is clear that the elasticity of the skin has begun to deteriorate. Loss of elasticity seems to be extremely present in the neck, bicep, and tricep areas. Although on several medications, there is no indication that he is experiencing adverse side effects related to pharmacological interventions. Skin on the legs appears to be excessively dry and a tad discolored. Skin appeared to be light pink with no indication of cyanosis, jaundice, or pallor. Skin was dry, but this can be expected of a patient in late adulthood. Upon palpation and inspection, no lesions, tumors, or wounds were discovered. Skin was relatively warm and appeared to be equal on both sides of the body as well. When testing turgor, skin remained tented briefly after being pulled. Hair was thinning on the scalp but felt normal and was distributed in a normal pattern. Hair on the legs was minimal and light, which may be related to the excessive dryness. Nails had a normal shape, size, and color with a relatively normal cap refill rate. Inspection of the toenails was not possible due to the infection located on his feet and the boots he was wearing to protect this. Although it was not inspected, patient does claim to have heel ulcers on both feet but gave no further information about that. The second examination performed is an abdominal examination in relation to the enlarged liver. As previously stated, patient had gallbladder surgery 5 years ago, but other than that, there are no surgical interventions related to the abdomen. Upon inspection, patient does have GERD, which is related to his esophageal issues, which were previously mentioned. No renal or bowel diseases that are known, but patient does suffer from hemorrhoids. There has been no abdominal change in weight, no fevers, chills, but patient has been experiencing diarrhea. He was unable to do a recall of his diet over the past few days, but was eating 5 to 10 minutes prior to the examination. All medication related to GI examination has been previously stated, but patient did mention that he used to be a smoker and quit decades ago. Upon inspection, abdomen seemed to be relatively rounded, but that can partially be attributed to the fact that he was in the sitting position. Color seemed normal, pink, and dry, same as most of his body, and there was no hair. All quadrants of the abdomen seemed to be equal, with both contour and symmetry. After auscultating each quadrant of the abdomen, bowel sounds were heard and seemed to be spaced apart at a normal rate. No bruits were heard. Palpation performed in each quadrant, first with light touch and then a deeper palpation. Upon palpation, the edge of the liver was felt, but the patient did not seem to be in any extreme pain. Again, the abdominal examination was performed while the patient was seated, so this may have affected the outcome. The 4 tests for peritoneal irritation came out negative as well. After completing these 2 examinations, there is a strong indication that a cardiac examination would be beneficial. According to Dr. J. Compton Burnett in his book, The Greater Diseases of the Liver, Jaundice, Gallstones, Enlargements, Tumors, and Cancer, and Their Treatment, there are several indications that enlarged livers can be tied to congestive heart failure. During the collection of patient history and the abdominal exam, it was clear that the patient has an enlarged liver. While there are many diseases an enlarged liver can be associated with, congestive heart failure is a main one. By performing a cardiac exam, congestive heart failure can either be ruled out as a cause for the enlarged liver, or it can direct doctors to do further tests on the heart. After going through the patient history and review of systems, there is a strong indication that a neurological assessment may be a pertinent examination. As stated earlier, the patient was a poor historian in terms of his medical history and current status. He also struggled with his short-term memory when I was collecting information from him. While this could be attributed to old age, it could also indicate cognitive impairment. However, some pharmacological interventions could also attribute to his confusion. Recognition and Initial Assessment of Alzheimer's Disease and Related Dementias is a journal from the U.S. Department of Health and Human Services, and it notes several medications that can cause cognitive impairment. Both aspirin and prednisone are among the medications listed on the chart in this journal, and they are also medications that this patient takes. A neurological assessment would allow a doctor to evaluate the mental status of the patient, and then it could be determined if there are any adverse side effects of the medication that must be addressed. If the neurological assessment expresses abnormal findings and pharmacological interventions are not related, then the patient can be further monitored and treated for cognitive impairment.